Yes, thank you. I tried to make it funny, but no one heard me, so I'll repeat it again. My name is Dr. County. Otherwise known as Dr. Karyn Tribble. I'm the Behavioral Health Director in Alameda County, and I definitely want to appreciate the esteemed panel members. I have to admit I felt somewhat guilty because I was a viewer at home with, yes, wanting to contribute to the conversation, but I really appreciate the expertise, and if you don't mind, just giving them another hand. I have been introduced, but I want to give a little context into my background. Full disclosure, my children say I need to update my resume. It says 25 years, and they do the math and say, Mom, isn't that closer to Ixnay? So for the next 20 years, it's still going to say 25 years, and I'm okay with that. But in terms of my background, and I only say this because the presentation that we'll go through is very textured. And the perspectives that our department has is very textured. And I definitely believe that having a holistic view to what's happening in the landscape is going to be critically important. So my background is, my husband says I've accumulated degrees like Tic Tac. I went to Howard University for my undergraduates, and then I got one master's in social services and social work at Bryn Mawr College, and then I got another master's in clinical psychology, and then I got my doctorate from the Philadelphia College of Osteopathic Medicine. So I am a little bit of an overachiever, but for me, knowledge really is power, particularly in governmental settings, because I will acknowledge that what you will hear is hopefully not meant to overwhelm you, but it's actually hopefully to give you context, because there is quite a lot happening. I have worked, as I mentioned before, back east, Philadelphia, Pennsylvania, New Jersey, Delaware, as well as California when we returned, I believe in 2003, prior to the Mental Health Services Act. So there is a lot happening, and this is actually unprecedented. The level of change that is occurring in the behavioral health space is unprecedented. So I will try to walk you through a little bit what is happening. So I just want to set some context, because I think it's incredibly helpful to understand. And as the panel mentioned, that the county, quote, has lots of responsibilities, but hopefully I want to really clarify what falls under the county and what we're seeing. This is not part of the slide, but I want to acknowledge, as was indicated, that we are seeing higher acuity, more serious symptoms, not only with our youth, but for the adults. And although this question wasn't posed to me, if you think about what we're seeing when a person comes and is presenting for 5150, now unfortunately the threshold is much higher. Even 15 years ago, what it required, quote, or how you presented to a clinician, you would have been 5150, no question, no doubt. In 2024, we are looking literally at data. This is not me just musing. The data from our emergency departments, from our psychiatric facilities, are showing a higher acuity. So even though we have less number of people in this county, I've worked with a lot of different programs that have really helped to stabilize people being 5150. Those that are incredibly complex and have a significant level of challenge as compared to many, many decades. So this is just an overview. I won't spend a lot of time on this because I think you really want to know the meat, but this is our mission, vision, and values in terms of what we aspire to do. What I'll walk through is what the government says we can do. So, as was already said, there is greater need. That is no doubt. We are not the only county, it is nationwide. And to some degree, it is worldwide in different ways. Complex trauma is a little different in other places, but it is greater than we've seen it. Obviously, we know substance use, what's going on. And although in this county, it doesn't feel like it, even if death rates sadly are decreasing, which is a positive, it's still incredibly complicated. Family member, regardless of ethnic status, socioeconomic experience, doesn't matter. We're all feeling it in some ways. Housing instability. I heard the commentary about what we're looking at. I'll be honest, it's hard to live here. And when I don't mean necessarily, I mean in the Bay Area in California. It is interesting, having worked in other counties and other states, and worked in hospitals, oversee hospitals and integrated services as well as behavioral health and everything. People who don't have a lot of resources, believe it or not, want to come to California because there are resources. The challenge is living in California in terms of housing. So I just want to keep that context because some of the programs and the legislations are targeting that very issue, and we will need to watch over the next several years to see if they're making the impact. And again, a lot of legislation, and what I would say what is really complicated is, as was mentioned, though we all know mental health and wellness across the board is critical, there is a shift to worsening issues, meaning the resources are shifting counties and other states to focus on those who are most complex and challenged, which is wonderful. However, I do challenge you to think about what that means in the wake. What does that mean for a child or youth? That way, I really appreciate Mr. Briscoe speaking to the opportunities that the schools now have, which is as a partner now, as opposed to a place of responsibility. But it does mean that there are going to be gaps, particularly for our adults. And so I want to be very concrete and speak to that so people can have a little bit of an awareness of what likely is going to happen. So this is an overview. All of this means is, as was described as our Alamy Alliance, and I'll back up for those that didn't hear that information. Believe it or not, county behavioral health departments are an HMO. Did anyone know that? Some people are chuckling like, yeah, we knew it. You tell us that when you don't serve our children and families. Well, why I say that is in 1991-ish, when there was a realignment essentially from the state to the counties to take care of the most severely mentally ill. If you remember that, for those of us around who worked in the 90s, you remember hospitals were closed. The thought was that we serve people in the community, the most severely mentally ill. Challenge us when the state did that. There weren't places for them to land. So the counties essentially were delegated the responsibility of creating a system of care and a network to care for those individuals. Initially, it started out as only treating and supporting those with the most severe mental illness. Those who were uninsured, those on Medi-Cal. That really was the purpose initially. It has evolved, and through MHSA initially, the system widened so that counties could, even as an HMO, serve people whether you had insurance, private insurance, diagnosis, didn't matter. It systematized the way counties worked. We happen to be a two-party plan, and I believe most counties are there, if not some are moving to there. In other words, we're an HMO both for mental health and substance use. So whenever you hear me speak in the words of behavioral health, I'm saying behavioral health because it counts as both. People with severe substance use, and people with severe mental illness. So we're an HMO, and that's what that means essentially. Believe it or not, as you see up there, so I'm happy to wear, I'm probably gonna get a hat that says the county. I'm proud to work in civil service, very much so. But we don't do it alone. And a lot of times we receive grace and happiness and really support from the community, particularly with our providers. I'm gonna insert my emoji there. Because we do believe, and we invest 100% of the services are delivered by providers, not, quote, the county. But the county and our leadership have invested in it to make that happen. So there's a partnership there. On this mental health side, it can be anywhere between 75 to 87% of it being community-based people doing that work. Facilities, hospitals, CBOs, schools. That is essentially what makes up that process. These are just examples of the funding sources. It's categorical. Anybody know what that means, categorical funding? It just means rigid. I don't believe we have state representative here, so I can say that. It means if the dollars come from a green source, you have to put it in the green bucket. If it comes from a yellow source, you have to put it in the yellow bucket. And sadly, we're not buckets. And so as a human being, county behavioral health departments have to work with leadership to see, this is the need, how can we bring the funding to support that clinic? No one has to know, or no one even may care, but we will put together multiple funding sources because they're categorical. We have to line it up and it has to serve that way because we're an HMO. The other thing that is often not talked about, I want to just spend a little bit of time, especially in the context of some of the changes that are happening, is like an HMO, there is what's called network adequacy. And I believe this is pretty critical in this district especially. What I mean by that is the state observes the distribution, quote, quote, of Medi-Cal beneficiaries. County behavioral health, as I said before, were initially started to support the most severe mentally ill. When it was realigned, theoretically the state assumed that they would be Medi-Cal beneficiaries, those that were released from the state hospitals, those who were suffering veterans. So that is how it was established. So there literally are heat maps. The state will look to see, i.e. in Alameda County, where do most beneficiaries live? Where do most receive services? And they will require counties to serve those areas. So remember I mentioned categorical funding, so counties have to crack their knuckles and figure out, okay, i.e. in Pleasanton, the number of Medi-Cal beneficiaries is not comparable to X city. How can we still support them given that they're categorical funding? For us, MHSA was very helpful in that because MHSA is agnostic to insurance. It doesn't matter whether you have it or not. We work with our providers. We want you to serve as many Medi-Cal beneficiaries, but we can serve you. So I just want to take that into context because that is often why you see the spreads that you see. The state dictates and then they check us. They literally will give sanctions, withhold funding. They place you on corrective action. And in some cases, for some counties, we've been doing a fine job, limited resources as we all have, but they will make sure that we spread the services where they've told us we did for those categorical dollars. If we get grants and other funding that aren't restricted, we have a lot more flexibility. So these are the types, and I think in the early part of this, many of you raised your hands, so you probably know this already, but these are some of the individuals with whom we work and family members. Another thing that often comes up is whether we should, quote, quote, provide services to some parts of our community, i.e. individuals who are incarcerated. We can't be specific and we have to be agnostic. Our responsibility is to serve a person wherever they are, whether it's a lock-in in an inpatient unit, but believe it or not, you can't actually draw down funding. Isn't that interesting if you're in a lock unit, except in some certain situations, and things are changing, or whether you're an incarcerated person. And I want to emphasize for county behavioral health, in this county, we are serving people from 0. We do have perinatal and prenatal programs and beyond. And we work hand in hand with providers to make sure we have enough while meeting, quote, the network adequacy standards as an HMO. This is not for self-promotion. In fact, I've been told we have way too many people, but I want to show why we have as many people and what it's organized. This is a high-level example of how our department, every county is different, is structured. And as you can see, clinical operations, and I'll unpack this in a moment, we have an office of medical director, health equity, and plan administration. The third is the most recent division we created because of all the disparities I believe that our colleagues have talked about prior on the panel that we're seeing. It just highlighted and it was exacerbated by the pandemic, but they always existed. Certain people are overly diagnosed, certain people are likely to be incarcerated, certain people are likely to be diagnosed but not treated and not do as well. Even, I would argue, those that have more resources. We have found that the more resources you have, it's a blessing, but it is not in the county behavioral health space in terms of what the state is requiring. So it's our responsibility to think more critically about what the services look like. Well, now that was exciting. There was a mic drop moment. I believe these slides will be available, but this just shows a breakdown. So if you look to the left, essentially, those are the services on the left-hand side. And so as I said before, in any given time, for example, we may have 800 or 900 employees in our department. We have about 4,000 to 6,000 providers in the community. These folks are responsible for those services. Even if one of our partners, which many of you are in the community or in the audience now, we're responsible for that. And why I say that again, we are considered an HMO delegated by the state. If you do well, we do well as a county. If you fail, we fail as a county. That partnership is something I really want to emphasize. Our Office of our Chief Medical Officer, as you see, that's for crisis. We have nurses, we have physicians, we have pharmacy services. We are the formulary. In other words, if a person, particularly if you have Medi-Cal, don't have insurance, we receive funding and opportunity and resource. We will make those available. And some are actually before they are available to the masses. Our pharmacy directors will make sure that people who have not the care and the support that they need get that. And integrated primary care services just means, which I think it came up earlier, federally qualified health centers. I think you're maybe familiar with those. Believe it or not, we'll put our emoji in the background. We don't get out in front, but we fund hundreds and dozens of positions and work because we found that people are ill and may not come through the county mental health door. They may not want to go see Dr. County. They may want to talk to their primary care physician. And our FQs advocated to us and said, can you make services available? Can you fund care coordinators? We said yes, and we're seeing a difference. Health equity, thank you. I will receive that. Yes, thank you. It's the truth. The county just says things. No, it's true. We don't often give ourselves credit, but there's so much investment that our county and our leaders are making. Health equity, we actually have a division, their job, if you see that peer certification, I think it was mentioned before, community health workers. You should be proud, I hope so. We were the first county in the whole state of California to say we want people with lived experience to be certified to draw down Medi-Cal. We know the work they do, whether you're a family member, lived experience yourself, alcohol, drug, mental health, working in the forensic center, and we were the first one to opt in. We're a little slower. We're working with our HR to make sure that the county positions match that, but we should be proud because our providers, way ahead of the game as well, were able to deliver those services with people who have lived experience. Family member, we are doing a complete overhaul, and I know there's some family members here. The purpose of that unit has had to change, and it is going to change in a much different way. The services are much more intensive, and more coordination is needed. And we have a whole unit with new leadership that we're bringing on board. And workforce education and training. I'm going to pause there, not so much about that, because it comes up later. And finally, plan administration. This side of the house pays our providers, integrates with our state, makes sure we are doing what's supposed to do, and are notified immediately by the state if the data doesn't match up. If they see that needs are overly served in here, they'll tell us. This side of the house really helps the ship go. We used to oversee, we had about 100 IS or IT folks that are with us. We still fund those positions, but now they're aligned to our broader agency. But nevertheless, that's a requirement of any county behavioral health. You have to have the infrastructure. This slide, I won't speak too much to it, but this is an example of a breakdown. So hopefully later, if you look at the slides, you can get a sense of, so what are all those folks, the county, what are they doing? This is what they're doing, and this is how it's organized. And again, these are the things that happen because it's the right thing to do, and it has to happen for infrastructure. Now, this slide, I'm not going to read this, but this is another way, if you wanted to know what's happening, this is how those systems of care are organized. These are the types of services. You'll see wellness centers and medication clinics. Again, whether it's us county or in partnership with our providers, that's where our leaders are accountable to make sure there is adequate network and that they're listening to those problems and we're pivoting. And again, believe it or not, the state often reaches out to us for feedback. Often. Alameda County, you really should be proud. We do not have everything. We have not solved it, but we are cutting edge in terms of how the state sees the administrative behavioral health services. Substance use, sober drug courts, sober living, residential. We need way more, and I appreciate Mr. Briscoe highlighting, even with what we have, we're not able to make it all work, but we are certainly trying to do more than we possibly can with the dollars that we do. And then, of course, as I mentioned, the forensic settings. This is the newest system of care because what we found in Alameda, based on our data, is that a person continues to be incarcerated and That's not good. I don't know how to say it in an elegant way, that's not good. They remain unhoused. So we created a system to follow a person and to try to prevent them from coming back to the system. And before, as I think it's been mentioned, behavioral health is made to be bifurcated. We unbifurcated it with the creation of the system, and that's why we did it. And we're finding that the outcomes are getting better when you actually have one person, care coordinators following a person and saying, no, don't go back to jail, don't go back to the Juvenile Justice Center, here, let me give you a resource. At the bottom, I won't spend time, but that crisis system of care, mobile crisis, has anyone heard of CAT? Yes, I'll put our little emoji. We partner with a provider and our EMS, and we funded and invested in an innovative program. Literally, it was approved by the state as an innovative program through MHSA, and now we have made it permanent. And there is a CAT car, that sounds very strange, C-A-T-T, it doesn't have kittens on it, but in any case, it is a crisis paired with an EMT, an EMS worker, and a clinician, so that the 911, when they're called, and we have trained them, they won't dispatch a police. They'll say, CAT, can you go? Mobile crisis, can you go? That is at the same time as 988. So there's so many things to, I think, address the questions around not relying so much on our law enforcement, but looking at the needs of the community. And at the bottom, believe it or not, did anyone know we have an employment division? No, I know crickets. We just do the work in the county. We need to do a better job of highlighting that. But we actually connect people to jobs, connect them to schools. I just interacted with a person a couple months ago who just graduated from UC Berkeley with her master's degree, one of our current clients. We will place and invest, and we also pay employers to employ them, because we know the intersection between homelessness and economics. Undoubtedly difficult for all of us even to live in California, let alone the Bay Area, let alone our clients. And so these are the services, again, that are offered across the system. And as you can see, again, housing and homelessness, we did have a division of housing that is now outside of us, but nevertheless, we invest and fund those operations. This is where it gets meaty. So if you aren't already drinking water, I would hydrate yourself, because this is the Game of Thrones that we are all in terms of behavioral health. Now, these are just some of the initiatives. I'm going to very briefly describe them after, but I want to show you these ones that are highlighted in purple are the ones that are on fire, both at the state and both on me. I see some nods. Can I get an amen for on fire? Yes. At the top, a lot of what came up was the bifurcation of the system. Okay? CalAIM, which is the one at the top, was the state's attempt to make it more integrated so that you don't have to repeat your story over and over again. So that if a person showed up in an outpatient clinic that was a primary care clinic, so a medical, not mental health, they would do the same screening form and then refer it to us or we to them. That is underway now. It's rolling out, and it is an attempt to help people in that way. What's different, and I believe that it was mentioned already, is this is for the mild to moderate level of care. Does anyone know what that means? As I've been mentioning, behavioral health is responsible for the moderate to severe, the most severe behavioral health illnesses. Again, MHSA helped us to serve people on the mild to moderate side. CalAIM, and this is, I think, what was mentioned in the earlier panel, this is where Alameda Alliance, we're the HMO for behavioral health, they're the HMO for healthcare. Alameda Alliance is here in Alameda County, and the other one is Kaiser. Anyone know Kaiser? I have a Kaiser card too, so I'm going to smile. No judgment on Kaiser. They are the second for us, and they're statewide. So that is where you heard in the discussion, CalAIM is to helping everyone be more responsible for the behavioral health services and network across not just county behavioral health. BHSA, I'll speak to a little bit. Care Court, I hope people heard the references earlier. Familiar with Care Court, I'm going to unpack that in a moment. Opioid settlement, anyone familiar with that? It's not highlighted, but kind of sort of. We are super pleased, I see the provider, that this county received is a class action lawsuit. I imagine you all remember when the tobacco settlement rolled out. It's the same principle, but for pharmacies and what have you that distributed culpable, and we opted into the class action. And so in this county, we are receiving about $75 million over 18 years. We are doing what we do best, receiving it and pivoting it and putting it back out. So some of the things we're paying for are pharmacy, prescriptions, long-acting injectables that we couldn't afford or that providers told us they couldn't afford, even in the jail. To some chagrin, some are saying, why are you doing this? Because we found that when people were being discharged from the jail, they did so without medication on board. They were not likely to quickly go back or even link with providers that are ready and able to serve them unless their medications, i.e., were long-acting. So, and through a partnership, we will be, county with partnership, providing mini grants to community-based providers to help us fight and provide helpful initiatives or even programs and services to abate the opioid issue. So any kind of program, honestly, we're following the model kind of innovations like MHSA did. If you think it works and you can do it, we have our, I almost don't want to say it, I don't know if I should, but anyway, we have a great partnership who's in this room, in this district, that will help us to distribute it equitably across the county. Smart care basically is how we're going to bill. We are going from, I know some providers are nodding like, Lord, don't tell us about smart care. What I'll say is county behavioral health systems literally, and our county is not an earlier adopter. We probably could have made some changes probably about 15, 20 years ago, but that's okay, we're making it now. We're going from a yellow screen, literally, with the bouncing yellow cursor, to a BlackBerry. Our goal is to move to a smartphone. That's what smart care is doing. In the middle of that, there is what's called payment reform, where the state has changed the way providers get paid. That is why I appreciate, again, the commentary around suggesting what providers need to align themselves with. It is incredibly important that you think of a bifurcated but braided funding system. Not just county, Medi-Cal, but also working with healthcare providers. CalAIM, again, is trying to help integrate that. Alameda Alliance, as was mentioned, absolutely important. The school district, the state is realigning funds to them so that each of us can be responsible and not as much where the county holds everything, even though the funding is categorical and we couldn't pay for everything. LPS, I'll speak a little bit about that in terms of SB 43. That is going to be incredibly important, and I do encourage people to, if you'd like to learn more, I believe it will be a Board of Supervisors presentation in December, but I would imagine people are familiar with 5150. Yes, are you familiar with 5585 for the youth? So that's the same thing, it's a psychiatric hold for youth. This only is for adults. The law has changed, and graciously our board has recognized the importance of it. We are implementing it. We also are setting up programs, more beds, more services. We're changing the way, because it actually changes the criteria for which a person can be placed on a 5150, which is phenomenal in the sense that it also allows for you to be placed on a hold if you have a substance use issue. That's wonderful. It really makes sense. However, can you imagine 100 people being placed on a 5150 and there aren't enough facilities? Can you imagine if our law enforcement weren't trained on who is appropriate for, who would theoretically, remember the Health Equity Division, who would likely be targeted first to be rounded up and placed on a 5150 hold? So many counties, most counties said we need to do this safely so that we don't create a problem downstream, but that's really significant. And finally, we have a settlement, both for the substance use, and there are some legal requirements that we're required to do. So again, this just says these are the things that we're working on integrating, because it is very Game of Thronesy these days. This slide, I encourage you to look at it. You don't have to memorize anything that I said, but it helps to give a very basic overview of the areas that were highlighted. What I didn't mention is, without knowing what was going to happen at the state, a lot of the laws that I just mentioned just recently came out. We underwent a 2-year strategic planning effort. Thank you to those that responded on survey, listening sessions, in person. You didn't block us. We emailed you. Some did, and that's okay. But we got the community primarily, certainly staff, feedback, and I'll unpack it in a moment, about what it should look like in our system. And then all the laws popped out, and then we realized, wow, but the good thing is the community pretty much was in line, as well as our own goals. So again, this is just a summary. This, did anyone play red light, green light when they were younger, or was I the only one? That's okay. And I'm not on any social media. The only thing I'll do is TikTok, only because they said they were going to ban it, so I just discovered TikTok. So I typically am very compliant, but I have an oppositional streak only at home. So this represents a very basic red light, green light, yellow light for your future reflection about some of the things that are happening. If you look to the left, it's red because it's on fire now. The state, again, has changed the way providers are going to be paid for providing behavioral health services. It used to be that we could pay you for cost. So if you had a $300,000 program that cost that much to run, we could pay you for that. Now, we are transitioning to fee for service. Anyone know what that means? Does anyone know we're in a workforce crisis? Okay, if you do the math, that means if you have vacancies in our provider network, you can't bill enough to cover your costs. What Alameda County did, and I'm very proud that we did that, is we extended the process by which providers can be reimbursed for cost. Because this transition is too much of a hard left turn, especially when we only have a BlackBerry that we're trying to get settled. But at some point, it's going to be very complicated. So again, for those providers in your room, your best bet, it truly is to partner with healthcare and behavioral health and mental health for services. Care Court, we talked about that. I'm going to briefly go over that very briefly. That's on fire. That's starting December 1st of this year. SB 43, that's the new law. That goes into effect January 1st of 2026. We can implement things before, and we are looking, and we'll be getting, hopefully, looking to our leaders, our county leaders, for support for some policy changes that will have to happen to get us ready for that. That happened before, but that's when we'll be implementing. And then BHSA, that begins July of 2026, July 1st. This shows just an overview of what was in our strategic plan. Our job is to look at the contents and to overlay it with everything that's happening. And so we are still in the process of disseminating it to as many people who will listen. It has been translated to all of our threshold languages, but it really says what our community said we need. That's the feedback. This is what was suggested by outside consultants that the county should adopt to be in a good place as far as the community in alignment. This hopefully summarizes the purpose of some of those new laws. Most believe that it is creating a holistic approach. It is not. Certain laws are. Integration is around CalAIM, Care Court, some peer reform, things like that. Population-specific focus, meaning the narrowing of what behavioral health counties can do, are those. And then community engagement opportunities to receive information is listed there. And purple is just, those are repeats. This is what we are focusing on for BHSA because it's going to transform everything. We want to tell as many providers who will listen and who will hear it has been passed is going to change everything significantly. Here's our budget yearly. And I see the supervisor, I'm going to say thank you for approving that. Of our $770 million budget, $200 is BHSA, will be, MHSA. Why I show that, and these are the sources of funds, but I'll move for the sake of swiftness. Someone must have been taking a 10, okay, thank you. A picture, but I apologize. So I'll go back very quickly if you were taking a picture. Okay. I still missed it. I believe these slides, thank you, thank you. This helps to understand how does it all relate to Prop 1. Briefly, Prop 1 changes everything. It targets higher population. Counting makes it so you can have mild to moderate issues or moderate to severe. Again, theoretically, HMOs of health will pick up what, or our schools, that's the state's vision, will pick up what MHSA will no longer fund. That's going to be critical because many of our partners didn't get that memo that they would start to be responsible for that. CARE Act, they'll talk about BCHIP, basically created money to build buildings. Fantastic opportunity. We are committed through 30 years of everything that was built. We have some of our providers here to help us build those facilities. SB 43, I mentioned, behavioral health bridge housing is basically temporary, long-ish term housing to help the most severely mentally ill. This just shows examples of the funding and the programs if you're interested in learning what Alameda County got in terms of that. We're looking at many different treatment opportunities and sites, some of which again are our partners here in this room that helped us to do that. Here's more examples of bridge housing and other things that we have been actively trying to draw down funds for. And here is the CARE Act. Will largely be focused on full service partnerships, which is funded by MHSA. Outreach programs we will have to rethink because those programs were not necessarily only centered on people with Medi-Cal. That's why that's highlighted. That will be impacted. If you are interested in learning about what it takes to do care court as a person, as a human being, we will have a website opening up. We're working with our courts. Fundamentally, if there is a person who has a psychotic disorder, not bipolar, I want to really emphasize that, a psychotic disorder and they have a substance use issue. So it can't be a substance use issue and it can't be another disorder. And they are suffering, they can get this care. This county already has community conservatorship, assisted outpatient treatment, which are court-ordered treatment. This will be another court-ordered treatment. This one I'm going to slide through because I don't want to overwhelm you, it's a lot. This is just the timing of MHSA. We are on the final year of MHSA. Just keep that in mind, then everything will change. It's almost over, I heard. The county is almost over. Yes, I will speed up for that. So this breaks down what the purpose of BHSA was. This one is where I'm going to focus quickly. I think I clicked very quickly, so I don't want to. This is what MHSA currently allows for. Okay? This, as of July 1st, 2026, is what it will look like. The most severe symptoms. Substance use is included. Now this is not with new money, but substance use is included. You basically have to now have a mental health diagnosis. And as was mentioned earlier, for schools, you will not. For MHSA, you will. Prevention is ending in terms of that. So all of those programs that we build will have to realign itself to Prop 1. Early intervention and treatment can happen, but not prevention. So this is an overview of what this huge transformational law will do to behavioral health systems and our providers. Very, very, very important to know. Housing is connected, certainly, in our county, again, we have a different constellation. It will go through our partners, but in the vision of the state is that housing and homelessness and behavioral health needs are integrated and should be treated as a holistic approach. So this is why those focuses are there. If you notice, I'm just going to point. You see suicide prevention is crossed out. Prevention will no longer exist, I'll say again. And for us in this county, that means about $25 million of services will be cut so that we can focus on the more severe community members, which is wonderful, and I want to be very realistic. It means that for those that will receiving those services or providers that will be funded, either they shift with us or there will be potentially areas with our community we're going to have to watch and monitor. won't go through, and I don't know why it looks like that, but this was an example in dollars of what the shifts will look like, shifting to more severe, and different ways to administer. And these numbers are essentially meaning we're going to add about 27 million in housing, about 22 million in full service partnerships, and we're going to reduce about $50 million in services. This is another slide. Again, I won't spend time on it, but this is a way to understand. If you look at that bar graph, the target is, i.e., $65 million for the blue bucket. The bucket is going to be everything else. We'll be shifting from 5 different components to 4, and we will be additionally providing 10% off the top to the state, going from 5% to 10%. So our current budget is about $120 million for everything else. We're going to have to move it to 65. A lot is changing. This slide just says a lot is changing. And it just, again, reinforces that this is just MHSA alone, or BHSA, which is, I won't go through this. If you want to learn more about BHSA and the timeline, that's what that's about. Here's some links, and the state is helping to, we don't know everything yet, and they're giving us more information, and they have not yet decided on some key fundamental changes that will happen, but we are following and working with the state directly. And these bonds are connected to BHSA. Fantastic opportunity. We will apply for everything we can get, and we're committed, because you have to be for 30 years to support whatever you build with those dollars. More information, I won't spend time. As you can see, this is what we're working with our providers and trying as much as we can to reiterate what was already said. Leverage, leverage, leverage. There's a lot. We want to talk to people as much as we can. I'm glad we're here. These are those opportunities that we hope that we'll be working together with the community to do. And this is putting it all together. If everything I said, you heard wah, 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 Dr. County, this helpfully gives a very high-level integrated approach to think of what's going on over the next 3 to 10 years, I would offer. The system is going to look very different than it did. You will have schools working alongside with Alliance and Kaiser, health plans, and behavioral health. Behavioral health will not hold the whole bucket any longer, which is a blessing, and it's going to be complicated because it means that we will not be able to do some of the services as we had before. Again, more summary, and that's all for the next 10 minutes. And I say the same thing. Thank you. Know if we even have time for questions, but
I did have a quick question. On the care court, because I think this is important for everyone, you said that it's going to launch on December 1. Do we have a website up for that, and how will that work?
yes, so we have a website. We're working with our IT through AC Health, and they should be on very soon. Within the next couple of weeks, and the courts also have a website. So any referrals can be made by family members, anyone. You're going to see it on our website. You're going to see forms. We're translating it in all of our threshold languages. So yes, coming soon.
And where do people go to access it? Do they go through Alameda County Health, or?
You will need to go, obviously, either to the courts directly, and you're going to see instructions. So technically, this is a court program that the state is requiring behavioral health to administer. You can come to us, there's no wrong door. We'll make sure that we help you fill out petitions and everything else. And so really there's no wrong place to offer a referral. We'll get you where you need to go.
Okay, that's good to know. Do we have time for just one more question?
Good morning, Dr. Tribble. My name is Claudia. I work at La Familia, and we have a lot of programming under the MHSA. And I guess my one question is the county going to help those CBOs transition into Prop 1? Because I know I'm part of a bigger collaborative with an FQHC, and it's a real concern. It's a real fear. And we do a lot of prevention and early intervention, and it's kind of scary that we've been around for almost 15 years, and now the community that turns to us, now we're going to be like, sorry, we can't do this anymore. So is the county going to help us?
I appreciate the question, yes. Now, I want to preface that by saying we initially thought, and I want to just say one thing, if I may to clarify. So, is there anyone that knew that Prop 1, or MHSA, was funded 2 years behind? So, thank you. So what that means is the money that millionaires, again, the millionaires are taxed at 1% of their income. In 2024, that tax and money won't be available to counties until 2026. Is there anyone in here who could plan a budget to go to Costco for 2026? Is there anyone? Okay, it's very difficult. So that's what our behavioral health. So luckily, other counties have had reversion, and if you don't spend it, because it comes with coin costs, it goes back to the state. We've done a really fantastic job, so says the state, in managing that. Even when there's a workforce crisis, when one CBO underspends, we'll try to liquidate and give it back to others. We give mini grants often, if there was a method to our madness. What we thought we would do is give financial support. We have heard from the state that that will not be possible. When BHSA hits, period, we're done. So then we are literally going through program by program, which are getting funded, how they're getting funded, and we're looking at, can they increase revenue, more reliance on Medi-Cal? Can they partner with another organization who does some of that critical work? Because again, in this county, we have so many programs, i.e. even in this area, that do prevention work, our healthcare providers, even if it's not funded, is there a way to leverage the funded? And so we're starting to work, we just recently got that update from the state. We're trying to work with our providers around ways to leverage. So for us, that's the type of support that we'll be able to offer, and hope that they'll be able to expend all their funds. We're also releasing very soon more mini grants for infrastructure and health preparation for the transition. And I don't know that other counties are doing that, but that's what we can do so that we're consistent with what the state says.
Thank you. Can I have a round of applause? So we're going to take a quick break. So 11:07. 11:07 we will be back here, and we'll be talking with our local providers. Thank you.